Bismillahirrahmanirrahim. So now we will start with the osteopetrosis, which is also called as the marble bone disease. Osteopetrosis means a failure of the normal bone resorption due to defective osteoclast, thickened, dense bones that are prone to fracture. Okay, so when the bone material is like clustered together, they will become. You can think of the analogy of glass. Like glass is very hard, but it is brittle as well. If it falls down, it can break down. So a failure of normal bone resorption due to the defective osteoclast, thickened dense bonds that are prone to fracture. Mutations, for example, the carbonic anhydrase 2 impair the ability of osteoclast to generate acidic environment. Okay, so mutation in the carbonic anhydrase 2 will impair the ability of the osteoclast to generate the acidic environment necessary for the bone resorption. Remember this thing, that for the bone formation we need an alkaline environment, and that alkaline environment is given by the alkaline phosphatase. But for the bone resorption we require the acidic environment, and that acidic environment is given by the uh, carbonic anhydrase, right? Yep. So that carbonic anhydrase is creating the acidic environment, and we also studied that acidosis leads to bone resorption and hypercalcemia in the bone. So let's come back. Mutation, for example, the carbonic anhydrase to impair the ability of the osteoclasts to generate the acidic environment necessary for the bone resorption. Overgrowth of the cortical bone fill the marrow space, that is pancytopenia. Okay, so overgrowth of the cortical bone will fill the marrow space, that will result in pancytopenia and extramedullary hematopoiesis, because if the marrow space is filled, so hematopoiesis will not be occurring, and if the hematopoiesis is not occurring, so resultantly we can experience pancytopenia and extramedullary hematopoiesis. That means the hematopoiesis may start occurring in the places that where it normally does not occur, for example the liver and the spleen, and maybe in the bones of the face or stuff like that. Can result in the cranial nerve impingement and paralysis due to the narrowed foramina. Why is the narrowing of foramina taking place? The because the bone formation has started taking place in the skull bones. So that is why there can be impingement and paralysis due to the, okay, so cranial nerve impingement and paralysis due to the narrowed foramina. X-ray shows diffuse symmetric sclerosis, that is bone in bone or stone bone formation. X-ray will show diffuse symmetric sclerosis, that is bone in bone or stone bone. Okay, so here you can see there's a bone inside a bone, the outer covering of the bone and then the inner covering of the bone. So let's come back. Bone marrow transplant is potentially curative as osteoclasts and are derived from the monocytes. So if we do the bone marrow transplant, that is potentially curative because the osteoclasts are derived from the monocyte, and if you're giving the bone marrow transplant, we're giving the precursor to the monocyte, so resultantly osteoclasts can be reformed. Okay, and osteomalacia and rickets. And remember that whenever we give the bone transplant will contain the monocyte which do not have this mutation that is causing the disease in first place. Now moving forward to the osteomalacia and rickets, most commonly due to the vitamin D deficiency. Histology: defective mineralization of osteoid, that is osteomalacia, or cartilaginous growth plates. Rickets only in children. Increase in unmineralized osteoid matrix and widened osteoid seams. Okay, so defective in osteomalacia rickets, there's defective mineralization. So mineralization problem is seen with the osteomalacia, while in osteoporosis there is no mineralization problem. So the defective mineralization of the osteomalacia, are or cartilaginous growth plates, rickets. Okay, so for the adults we see osteomalacia, that is there is defective mineralization of the osteoid. But if the defective mineralization of the cartilaginous growth plate is occurring, so that is something that we call rickets, and that is seen only in the children. Increase in the unmineralized osteoid matrix and widened osteoid seams. Okay, X-ray will show osteopenia, for example looser zones, pseudo fractures in osteomalacia. Okay, and epiphyseal widening and metaphyseal cupping spraying in the rickets. So epiphyseal widening and metaphyseal cupping or spraying will be seen in the rickets. Presentation: children with rickets have pathologic bow legs or genu varum. Here is a picture of that. Here you can see the pathologic bow legs, that the legs are going inside but the knees are moving outside. So that is genu varum. Bead like costochondral junction, that is called as the rachitic rosary. So this is the rachitic rosary sign over here and also over here. Then due to the deposition of osteoid at the costochondral junction, craniotabes or soft skull, pigeon breast deformity of the chest can also be seen, and frontal bossing will also be present. Findings: decreased vitamin D, decreased serum calcium with increase in PTA secretion and decreased serum phosphate. Hyperactivity of the osteoblast will cause an increase in the alkaline phosphatase. So decreased vitamin D will lead to decreased serum calcium, and increased parathyroid secretion will lead to decreased serum phosphate. Hyperactivity of the osteoblast will lead to an increased level of alkaline phosphatase. Okay. Then moving forward, we'll talk about the rickets in children and osteomalacia. Basically, it is the same disease with different names in the adults and the children, and also you may say that they are children and they are pediatric and adult counterpart of the same disease. Okay, so that is an easy way to say that. Risk factors for the rickets are exclusive breastfeeding, inadequate sun exposure, increased skin pigmentation in dark-skinned individuals, and maternal vitamin D deficiency. For the cranial manifestations, craniotabes, that is ping pong ball skull, delayed frontal closure, frontal bossing, hypertrophy of the costochondral joints, that is rachitic rosary, and widening and thickening of the wrists, and femoral and tibial bowing can also be seen. So these are the manifestations. For osteomalacia, pathophysiology is decreased mineralization of osteoid. Here it was the decreased mineralization of what? There was no pathophysiology of that, but in this picture, you find the decreased mineralization of the cartilaginous growth plates. And here there is decreased mineralization of the osteoid, most commonly due to the inadequate availability of calcium and phosphorus. Causes: vitamin D deficiency, malabsorption, intestinal surgery and celiac disease, chronic kidney disease and tubular acidosis. Symptoms and signs are bone pain and tenderness, muscle weakness and impaired gait, and fractures. Pagets disease of the bone, that is also called osteitis deformans. Pathogenesis: imbalance between the osteoclast and osteoblast function, bone remodeling. So imbalance between the osteoclast and osteoblast function, there is bone imbalance between bone remodeling is called as the Paget's disease. Increased osteoclastic activity works independently without a signal from osteoblast, caused by the environmental factors and gene mutation, for example, affecting the rank osteoprotectin that result in excessive rank signaling and NF-kappa B activation. So it is caused by the environmental factors and gene mutation, for example, affecting the rank osteoprotectin that result in excessive rank signaling and NF-kappa B activation. This leads to increased osteoclast differentiation and activity. Okay. How is it caused? It is caused by the environmental factors and gene mutation, for example, affecting the rank and osteoprotectin that result in the excessive rank signaling and NF-kappa B activation. This leads to increased osteoclast differentiation and activity, followed by increased osteoblastic activity that forms poor quality of the bone. Okay. Stages of Paget's disease are lytic, mixed, sclerotic, and quiescent stages. So there are 4 stages of the lytic disease. Okay. So firstly we'll find increased osteoclastic activity that will be followed by increased osteoblastic activity. Stages of the Paget's disease. Number 1 is lytic osteoclast, the increased osteoclast that appear abnormally large with an excessive number of nuclei. So lytic, the first stage is lytic, that is mediated by the osteoclast. So there will be an increased number of osteoclasts that appear abnormally large with an excessive number of nuclei. Mixed, that is osteoclast plus osteoblast, increased osteoblastic bone formation with persistent osteoclastic activity. The newly made bone is abnormal with interspersed area of disorganized lamellar and woven bone. Sclerotic or osteoblast, so characterized by continued osteoblastic bone formation and remodeling that result in the dense, hypovascular, mosaic pattern of the lamellar bone with irregular, haphazardly oriented sections separated by the prominent cement lines. Okay, so it is characterized by the continued osteoblastic bone formation and remodeling that result in a dense, hypovascular, mosaic pattern of the lamellar bone with an irregular, haphazardly oriented sections separated by prominent cement lines. Then we have a quiescent phase, that is minimal osteoclast and osteoblast activity. So the story begins with osteoclasts, then osteoblasts come in the picture along with osteoclasts, then it is just osteoblasts that are remained, and ultimately the quiescent stage in which everything is over. The end result is thickened, deformed bone that is weaker than the normal and prone to fracture. Okay, so here you can see the pathophysiology. So firstly we'll have osteolytic phase. Let me zoom it in. So osteolytic or osteoclastic dominant phase is the one in which we have a lot of osteoclasts performing their activity of the bone resorption. Second phase is, this was the number 1 phase, and the number 2 was mixed phase. In the mixed phase, we have osteoclasts along with osteoblasts. There will be new bone formation by the osteoblast and bone resorption. New bone formation by the osteoblast, while the old bone resorption that is caused by the osteoclasts. Then third stage is osteosclerotic phase or osteoblast dominant phase. There is weak, thickened and woven bone. So there is weak, thickened, woven bone will be seen. Got it. Now we'll talk about cement lines. Cement lines which are shown by the arrows. Like if I could, I'm encircling the semen line over here, and there's another semen line over here. So just give me a minute. Yep. So these are two semen lines over here and over here. So these two semen lines are hallmarks of the bone turnover. In Paget's disease of the bone, disordered and excessive bone remodeling result in a mosaic pattern on microscopic examination, seen here with many chaotic semen lines. So let's come back. Just give me a second. So histology, mosaic pattern of the woven and lamellar bone osteocytes within the lacunae in chaotic juxtapositions. What is mosaic pattern? Mosaic pattern of the woven and lamellar bone. I guess this is a mosaic pattern in which we have woven and lamellar bone osteocytes within the lacunae in chaotic juxtaposition. There will be cement lines, and along with that, long bone chalk stick fracture. Okay, so chalk stick fracture of the long bones. Along with that, we find cement lines and mosaic pattern of the woven and lamellar bones osteocytes within the lacunae in the chaotic juxtaposition. Presentation, bone pain, increased head size. So that is very important, that the patient will complain you that my head size has started increasing, and my heads which are previously just exactly of my size of the size of my head, they don't fit anymore. So increased head size due to the skull thickening. Hearing loss is common due to auditory foramen narrowing, line-like facies, and isolated elevation of the alkaline phosphatase. So in the Paget's disease, we find bone pain, increased head size due to skull thickening. Hearing loss is common due to auditory foraminal narrowing, line facies, and isolated elevation of the alkaline phosphatase. The labs will show serum calcium, phosphorus, and PTH level are normal, and there is an increased alkaline phosphatase. Complications are high output heart failure. Vascularization associated with the bone remodeling creates a AV shunts that is very high yield. That there will be high output heart failure in the case of Paget's disease. But why will there be a heart failure, high output heart failure? Because suppose this is a newly forming GUI bone, and in that bone we need new vascularization as well. So in the new vascularization, there is the possibility that a high pressure system, that is maybe a small artery or an arteriole, is connected directly to a venule or a vein, and AV shunts are formed, small AV shunts or maybe large AV shunts. So in that case, the peripheral resistance has decreased dramatically, and the heart rate, the cardiac output also increases. So because of the AV fistula formation, the cardiac output increases, and we find the person to be facing high output heart failure. Increased risk of osteogenic sarcoma is also present with the Paget's disease that can develop into cancer. Treatment is bisphosphonate and calcitonin. Okay. Osteogenic sarcoma and treatment is with the bisphosphonates and calcitonin. Bone pain and elevated alkaline phosphatase level in an elderly patient can occur with the osteoblast metastasis and the Paget's disease of the bone. So here you can see that the calvarium is getting more and more thicker over here and all that. And I guess these are these are either metastases or the nidus of bone remodeling. Okay, so bone pain and elevated alkaline phosphatase level in elderly patient can occur with the osteoblast metastasis and the Paget's disease of the bone. Okay, then we'll talk about osteonecrosis or avascular necrosis. We have studied about this condition so many times, about the femoral neck and a lot of other areas. Let's read it now. Infarction of the bone and marrow, usually very painful. Most common site is the femoral head watershed zone due to insufficiency of medial circumflex femoral artery, a branch of profundus femoris artery that supplies the neck of the femur. Okay. Presentation. Here you can see the watershed area. Why so? Because there is a branch of the obturator artery that is in the ligament to the head of femur. That is the ligamental artery basically. So branch of the obturator artery supplying this zone, and the branch of the profunda femoris artery, that is medial femoral circumflex artery, that is supplying this zone. In between these two areas, there is this territory that is the watershed zone. If there is any decrease in blood supply, maybe due to the fracture in this particular area, or maybe due to some other reason, some hypovolemia, stuff like that. So watershed areas are the areas which are most affected by the hypovolemic shocks or any kind of hemodynamic stress. So that is why this area in the head of femur will be undergoing avascular necrosis. Presentation. Pain on weight bearing, decreased range of motion, and no swelling, erythema, or warmth in the surrounding areas. Causes: cast, bent legs, corticosteroids, alcoholism, sickle cell disease, trauma. The bends, that is Caisson depression, the bends which are the Caisson or decompression diseases, leg, clave, Perthes disease, that is idiopathic. We have discussed about this disease, I guess. And then we have Gaucher's disease, slipped capital femoral epiphysis. Slipped capital femoral epiphysis. Okay, we have discussed these two weird conditions, and the other conditions we know very well. So the mnemonic is cast, bent legs, corticosteroids, alcoholism, sickle cell disease, trauma. The bends, which are Caisson's disease, Caisson or decompression disease, it is when the person, the deep sea diver who ascends very rapidly towards the sea level, so we can develop Caisson disease. Then we have leg clave perthus, LCP disease, that is idiopathic. Then yeah, LE, we're done with LE. Then G is for the Gaucher disease, and S is for the slipped capital femoral epiphysis. So we have lateral femoral circumflex, which is anteriorly supplying, while the medial circumflex femoral is supplying posteriorly. Moving to the next one, lab values in the bone disorder. So these are different lab values in the different kind of bone disorders. So let's do them one by one. Osteoporosis, serum calcium, phosphate, alkaline phosphate, and parathyroid hormone, all the lab values are pretty normal. The comment is that there will be a decreased bone mass only in the case of osteoporosis. In the case of osteopetrosis, serum calcium may be decreased or may be normal, and the rest of values of phosphate, alkaline phosphate, and parathyroid hormone are all normal. Why will serum calcium be low? Because normally some amount of calcium is entering the serum due to the resorption of the bone, and if the bone resorption is not taking place, so resultantly the calcium level may be low. So the dense brittle bones, calcium decrease in severe malignant disease. Okay, in that particular condition, calcium will be decreased. Otherwise, the calcium level is also normal. Paget's disease of bone, serum calcium and phosphate are normal. Parathyroid hormone is also normal. Alkaline phosphatase may be elevated. Abnormal mosaic bone architecture. Osteofibrosa cystica, primary hyperparathyroidism. The serum calcium is elevated. The alkaline phosphate is also elevated, and parathyroid hormone is also elevated in the case of osteitis fibrosa cystica can happen because of a lot of conditions. If we talk about primary hyperparathyroidism, so in the case of primary hyperparathyroidism, okay, so in the case of primary hyperparathyroidism, the serum calcium level is increased because PTH causes increased calcium resorption. The alkaline phosphatase level is increased because PTH favors the bone resorption, and parathyroid hormone will also be high, but the phosphate will be decreased because the PTH favors the phosphate excretion. Comments: brown bone tumors due to the fibrous replacement of the bone's subperiosteal thinning, idiopathic or parathyroid hyperplasia, adenoma and carcinoma. Secondary hyperparathyroidism, serum calcium will be low. Okay, and the low serum calcium is basically most of the time the lowered serum calcium is the stimulus for the release of parathyroid hormone. So hyperparathyroidism is secondary to the low serum calcium levels. The phosphate level is elevated. Alkaline phosphatase and parathyroid hormone levels are also elevated. Comments: often as compensation for the CKD, decreased phosphate excretion and production of activated vitamin. Okay, so there is a decreased phosphate excretion and decreased production of activated vitamin D. Osteomalacia and rickets, they will decrease the level of serum calcium, decrease phosphate level, and increase alkaline phosphatase and parathyroid hormone level. So the person will get soft bones. Vitamin D deficiency also causes secondary hyperparathyroidism. Soft bones and vitamin D deficiency will also cause secondary hyperparathyroidism. Hypervitaminosis D, increased serum calcium, increased phosphate level, and in hypervitaminosis D, what happens? Okay, give me a second. In osteomalacia or rickets, we get decreased serum calcium, decreased serum phosphate, because we are not having this, the bone mineralization is not taking place over there. And alkaline phosphatase and parathyroid hormone will be elevated in both these conditions because we get decreased level of serum and decreased phosphate, blah blah blah. So make some analogy out of that as well. In the case of hypervitaminosis D, because of any reason if the vitamin D level is in excess amounts, so the calcium will be high because it favors the calcium retention. Phosphate level is also high because vitamin D favors the phosphate retention. Then alkaline phosphatase level will be normal, and the parathyroid hormone will be low. That is a secondary decrease in the parathyroid hormone because of excessive calcium and hypervitaminosis, because vitamin D also regulates the release of parathyroid hormone. It is caused by oversupplementation or granulomatous disease, for example, sarcoidosis. Okay. Malignancy associated hypercalcemia. Malignancy associated hypercalcemia. The first one is parathyroid hormone related peptide production. 80% of the malignancy induced hypercalcemia. 80% of the malignancy induced hypercalcemia tumor, squamous cell cancer, for example, lung, head, neck, esophagus, renal and bladder cancer, ovarian and endometrial cancer, and breast cancer. All of these tumors can cause the production of parathyroid hormone related peptides, and it is an 80% malignancy induced hypercalcemia. Okay, in 80% of the malignancy induced hypercalcemia, the PTH-RP is the culprit. The mechanism is activation of the parathyroid hormone receptor, excessive bone resorption will be there. 125 dihydroxy vitamin D production. Lymphomas of all type can cause the excessive production of vitamin D. Excessive gut absorption of calcium. Bone metastasis, breast cancer, multiple myeloma, and lymphomas. Release of local factors, for example, cytokines to stimulate the bone resorption. Ectopic parathyroid hormone production is very rare, and the tumor is variable, and that will result in the bone resorption. If there is ectopic parathyroid hormone production, there can be the release of parathyroid hormone related peptide, but ectopic production of PTH in itself is very rare, and the tumor can be variable. So if it is rare, so any tumor can cause the production of PTH-RP if it becomes so undifferentiated. Uworld point is humoral hypercalcemia of malignancy, or HHM, hypercalcemia but not focal lytic bone lesions caused by the secretion of parathyroid hormone related peptide PTH-RP. Hypercalcemia in HHM, humoral hypercalcemia of malignancy, is more severe than that of primary hyperparathyroidism. So hypercalcemia in humoral hypercalcemia of malignancy is more severe than the primary hyperparathyroidism. Primary bone tumor metastatic disease is more common than primary bone tumor. So now we're talking about the bone tumors. So the metastatic disease is more common than the primary tumor. So it is true about most of the tissues of the body that the metastasis to the bones and to the liver and to any other organ of the body is more common than the primary tumor of that particular location, which in our case right now is the bones. Tumor type, first we will talk about osteochondroma. So by saying this, now we'll go to the primary tumors now. Metastasis is always most common, but we're not discussing it right now. The most common type is osteochondroma. Epidemiology, most common benign tumor, males less than 25 years of age. Location, lateral projection of the growth plate, metaphysis for the long bone near the growth plate, and stops growing with the growth plate closure. Okay, lateral projection of the growth plate. The osteochondroma is the lateral projection, as you can see in this picture. It is the lateral projection of the growth plate. Metaphysis of the long bone near the growth plate will stop growing with the growth plate closure. Okay, so it stops growing with the growth plate closure. Characteristic, cartilage capped tumor attached to a bony stalk. So you will find a cartilage capped. Here you can see the cartilage cap, and then bone and marrow. So it is a cartilage capped tumor that is attached to the bone stalk. Lateral bony projection continuous with the bone marrow space. Rarely transformed to the chondrosarcoma. It is a very rare happening for the osteochondroma to be transformed into chondrosarcoma. That is the malignant version of this osteochondroma. Most are solitary. Multiple are part of multiple hereditary exostosis syndrome, autosomal dominant. So most of them are solitary. Multiple are part of multiple hereditary exostosis syndrome, or MHE syndrome, MHES, multiple hereditary exostosis syndrome, or autosomal dominant condition. It is an autosomal dominant condition which can present with multiple osteochondromas. Otherwise, mostly it is solitary. So here you can see what was that? It was the development of the osteochondroma beginning with the outgrowth from the epiphyseal cartilage. So it begins as an outgrowth from the epiphyseal cartilage, and then it causes the full-blown osteochondroma formation. What is osteoma? Osteoma occurs in middle age. So surface of the facial bones, as you can see an osteoma over here, associated with a Gardner syndrome, that is familial adenomatous polyposis plus retroperitoneal fibromatosis plus multiple osteomas. So the Gardner syndrome is a polyposis condition which is associated with the familial adenomatous polyposis. Along with that, if there is a triad of the FAP with retroperitoneal fibromatosis along with multiple osteomas, so that condition is called as Gardner syndrome, and that is the most common condition in which we find osteomas. Moving to the next disease, that is osteoid osteoma. Adults less than 25 years of age and males. So now there are osteoid osteoma is, I guess, a kind of osteoma. So adults less than 25 years of age, males are more prone to develop osteoid osteoma than females. Cortex of the long bone most commonly seen in diaphysis. So the osteoid osteoma develop in the cortex of the long bones and most commonly seen on the diaphysis. Okay, so I guess this is an osteoid osteoma, maybe. There is a benign tumor of the osteoblast with osteoid core that is radiolucent. Osteoid core will be radiolucent, the black one. That is osteoid, surrounded by the rim of reactive sclerotic mass, that is osteoma. present as bone pain, worse at night and relieved by NSAIDs, bone mass less than 2 centimeter and radiolucent osteoid core. So there will be a radiolucent osteoid core. Okay, so radiolucent osteoid core is there and the bone mass will be less than 2 centimeter. Okay, then let's talk about osteoblastoma. Osteoblastoma is a vertebrate benign tumor of the osteoblast, similar to the histology to the osteoid osteoma, larger size more than 2 centimeter, pain unresponsive to NSAIDs. So here you can see osteoblastoma. It is also a benign tumor of the osteoblast, similar in histology to osteoid osteoma. If it is more than 2 centimeter, it is osteoblastoma. If it is less than 2 centimeter, it is called as osteoid osteoma. Okay, this one is responsive to NSAIDs and this one is not responsive to NSAIDs. So there is a difference between them. I will try to cover the sketchy mnemonics for these things because if I got the time to cover the pathology section of the sketchy, I will try to cover them because they're otherwise they're like very boring details of the bone and all that. So I will try to cover them if I could, but I'm not guaranteeing that because I have a lot more to cover. So let's come back chondroma. Medulla of the small bones of hand, and feet can develop chondromas. As you can see in this picture, this is a chondroma in the I guess that is the intermediate phalanges maybe. Okay, so bone tumor of the cartilage is a benign tumor of the cartilage. So benign tumor of the cartilage is called as chondroma. Giant cell tumor that happens in 20 to 40 years of age. Epiphysis of the long bones open in the knee region. Locally aggressive benign tumor. Neoplastic mononuclear cells that express the rank L and reactive multinucleated giant cells, which are osteoclast-like cells, and osteoclastoma. Soap bubbles appearance on X-ray. Okay, soap bubble appearance will be seen on X-ray. After that, these are I guess the giant cell tumor and soap bubble appearance. This is the soap bubble appearance that you can find on X-ray. So then we have tumor type osteosarcoma or osteogenic sarcoma. Okay, so now we are going to talk about the malignant bone tumors. Previously we have seen the benign bone tumors. These are the benign bone tumors. The benign tumors of the bone. Now we are going to talk about the malignant bone tumors. So the malignant bone tumors include the osteosarcoma or osteogenic sarcoma. Accounts for 20% of the primary bone cancer. Peak incidence of primary tumor in the males is less than 20 years of age. Less common in the elderly, usually secondary to predisposing factors such as the Paget's disease of bone infarcts, radiation, familial retinoblastoma, and Lee from any syndrome. Location: metaphysis of the long bones open in the knee region. Characteristics: pleomorphic osteoid producing cells, malignant osteoblast. Okay, so malignant osteoblast. I'm sorry. Yep. So malignant osteoblast. Pleomorphic osteoid producing cells, malignant osteoblast, present as painful enlarging mass on the pathologic fractures. Codman triangle. From the elevation of periosteum or sunburst appearance on X-ray, think of osteochord bonefish swimming in the sun. So this is the most frequently asked question about the Codman triangle. They often give you a picture of the Codman triangle or the sunburst appearance, and then they ask you about the diagnosis or stuff like that. It is aggressive and primary, usually responsive to the treatment, surgery, chemotherapy, and poor prognosis for secondary one. Okay, so here you can see the Codman triangle. I guess this one. No, it's a sunburst appearance, but also Codman triangle. So this is the Codman triangle like this. Then we have this is the tumor, the CT scan image of that, and I don't know, maybe if it is a sunburst appearance radiating outwards. I guess I don't know. So this is the location is metaphysis of the long bones, open the knee region. Then moving forward to the chondrosarcomas. Medulla of the pelvis and central skeleton versus the chondroma, small bones of the hand and feet. Tumor of the malignant chondrocytes. Ewing sarcoma, most common in Caucasians, generally boys less than 15 years of age. Diaphysis of long bones. At the location for the Ewing sarcoma formation is the diaphysis of the long bones, especially the femur pelvic flat bones. The anaplastic. So the finding, I guess this is the finding column. So characteristic findings are anaplastic small blue cells of the neuroectodermal origin that resemble the lymphocytes, different from the condition with similar morphology, for example, the lymphoma or chronic osteomyelitis. By testing for the T1122, we differentiate it from the other such conditions by testing for the translocation from 11 to 22 fusion protein EWS FLI1 or maybe FL11. So it is 11 plus 22 is equal to 33. Patrick Ewing jersey number. So there's some player Patrick Ewing. Okay, we have to see the Patrick Ewing first. Patrick Eving. So Patrick Ewing is this player, and the number of Patrick Ewing's jersey is 33. So now let's, this mnemonic will make more sense to you because the jersey number of this particular person is 33. So if we see over here, the translocation from 11 to 22 takes place in the Ewing sarcoma. Okay, onion skin, periosteal reaction in the bone. So because of periosteal reaction in the bone, we will find an onion skin appearance. Onion skin appearance is very characteristic of a lot of diseases. For example, the onion skin appearance is found in the patient with the Tay-Sachs disease, in the lysosomes. The onion skin appearance is seen in the patient who have hyperplastic arteriolosclerosis. Yeah, and then onion skin is also found in the patients who have that condition that is called as chronic sclerosing cholangitis in the bile ducts. And now we have onion skin pattern in the periosteum of the person having the Ewing sarcoma, and that is happening because of the periosteal reaction in the bone. Aggressive with early metastasis with but responsive to chemotherapy. So it is aggressive with early mets but responsive to chemotherapy. So Ewing sarcoma, sheets of small round cell with a scant clear cytoplasm. We can see the sheet of small round cells with scant cytoplasm. And if we find the onion peel periosteal reaction, so here you can see multiple layers are present, like one, oh no, not like that. So there are multiple layers like 1, 2, 3, 4. So find these layers in this region over here, and that is an onion peel pattern of periosteal reaction. Moving forward to the summary of these reactions. So in the diaphysis, we have round cell lesion, Ewing sarcoma and myeloma. Round cell lesions, which can be Ewing sarcoma or myeloma. If the diaphysis contain round cell lesions, so they can either be Ewing sarcoma or myeloma. How will we differentiate? How will we differentiate between the two conditions? We'll check for the translocation from 11 to 22. Then fibrous dysplasia. After that, simple bone cyst can also be a lesion. Then in the metaphysis, we can find osteosarcoma or osteochondroma. Osteosarcoma is a malignant version of osteochondroma. Then in the epiphysis, we can find giant cell tumor. So these are locations of different tumors. They are not all of them, but most important of them are listed in this picture. Then we'll talk about bone metastasis. Most metastasis from adults, most metastasis that come to the bone in adults who are more than 40, they can be dual or bilobed organs. Okay, so bone metastasis can be from the dual or bilobed organs like prostate or breast or kidney or lungs. So the most of the metastases are coming to the bones through these bilobed organs. But in the case of children, the bone mets are coming from the neuroblastoma, the Wilms tumor, osteosarcoma, Ewing sarcoma, and rhabdomyosarcomas. So bone mets are coming from these sites, and for the adults and children, we have different sites. For the adults, the bilobed organs or the double organs, like the prostate is a bilobed organ. You can't say it bilobed, but maybe you can say it. Breasts are two, like we have two breasts, and then kidneys, which are double organ, and the lungs, which are multilobed, or for the left it is bilobed. And then the children, the neuroblastoma, Wilms tumor, osteosarcoma, Ewing sarcoma, and rhabdomyosarcoma can cause metastases into the bones. Typically multifocal, but kidney and thyroid metastases are solitary. Most involve axial skeleton, for example, vertebral column, the pelvis, ribs, skeleton, and sternum, due to the multitude of capillaries and slow blood flow, or because of multitude of capillaries and slow blood flow, or to the proximal femur. Okay, proximal femur is not a part of axial skeleton, but that is a favorite location for the cancerous metastasis to go. So remember these locations. And the solitary mets come from the kidney and thyroid gland. Then these are bone mets. They can either be osteoblastic or osteolytic, or can be mixed. For the osteoblastic, remember the prostate. That is very important. That is very high yield as well. Just give me a second. Yep. So the osteoblastic ones are coming from prostate cancer, the small cell lung cancer, or Hodgkin lymphoma. The osteolytic ones are coming from the multiple myeloma, non-small cell lung cancer, non-Hodgkin lymphoma, renal cell carcinoma, and melanoma, while the mixed ones are coming from the gastrointestinal and breast. Then we have lesions stimulating the primary neoplasm. Firstly, we'll talk about fibrous dysplasia. So in the case of fibrous dysplasia means abnormal growth that leads to benign tumor with the components of normal bone present but undifferentiated. So these are benign tumors with the components of normal bone which are present but they are undifferentiated. And what is meant by fibrous? So bone replaced by the fibrous tissue due to failure of normal lamellar bone, weak bone that is prone to fracture, caused by somatic gain of function mutation in the GNAS1 gene. Okay, although fibrous dysplasia is genetic disorder, it is caused by the gene mutation that's not passed from the parent to child, that is post-zygotic mutation. The gene encodes the alpha subunit of the stimulated G protein, GS protein. This mutation is also in the pituitary adenoma also. This mutation also in pituitary adenoma also. This mutation produces constitutively active GS protein, leading to the increased or enhanced cellular proliferation. It will interrupt the osteoblast differentiation from the precursor, which will result in the deposition of collagen, immature osteoblast, and the irregular bone. Epidemiology: children and adolescents who are less than 15 years are most affected by the fibrous dysplasia of the bones. Diagnosis: X-ray will show bubbly lytic lesions. So what are the bubbly lytic lesions? These are, I guess, the bubbly lytic lesions. Maybe there's a bubble over here and maybe over here, and a lot of bubbles can be seen in this picture. So these are called as bubbly lytic lesions in the case of fibrous dysplasia. Okay. Histology: well circumscribed intramedullary region composed of curvilinear trabeculi mimics the Chinese letter. So histology will show well circumscribed intramedullary regions which are composed of curvilinear trabeculi, and they mimic the Chinese letters. Several overlapping clinical patterns and presentation: monostotic, polyostotic, Maza-Brod syndrome, and McCune-Albright syndrome. Okay, so what is monostotic type of fibrous dysplasia? It is involving a single bone. Polyostotic, it is involving multiple bones. Children less than 15 with progression into adulthood. So polyostotic fibrous dysplasia can progress into adulthood. So these are the bones which are most commonly involved: femur, then skull, tibia, humerus, ribs, fibula, radius, ulna, mandible, and vertebrae. The most common site for the fibrous dysplasia in a polyostotic type of fibrous dysplasia is the femur. The least one is vertebrae, and the other ones come in between, so make some mnemonic for yourself and stuff like that. Present with a bone pain, shoulder and pelvic girdle involvement causing crippling deformities and fractures. What is Maza-Brod syndrome? Fibrous dysplasia are usually polyostotic with soft tissue myxomas. Okay, there will be soft tissue myxomas as well. McCune or Albright syndrome. Clinical picture is a triad of fibrous dysplasia. Polyostotic is unilateral, multiple osteolytic appearing lesions, pathologic fractures. So fibrous dysplasia is polyostotic and unilateral, multiple osteolytic appearing lesions, pathological fractures. Endocrine abnormalities most commonly result in the precocious puberty, onset of the secondary sexual development before the age of 8 in the girls. Okay, so the McCune-Albright syndrome is associated with the endocrine abnormalities most commonly result in the precocious puberty, onset of secondary sexual development before the age 8 in the girls, and then cafe or late sports. Usually the first manifestation of McCune-Albright syndrome, unilateral with irregular coast of main border. Okay, coast of mine, what's that? With an irregular coast of mine border. Okay, McCune-Albright syndrome, pathogenesis: mosaic somatic mutation in the GNAS gene encoding the stimulatory alpha subunit of the G protein. Constitutive activation of the adenylate cyclase lead to the overproduction of the several hormones. Clinical feature is cafe or late sports. Endocrine abnormalities, for example, precocious puberty, hyperthyroidism, and fibrous dysplasia. Now here you can see osteoarthritis and rheumatoid arthritis. There is a difference between both of them. Okay, so first we will talk about osteoarthritis. Pathogenesis: mechanical, wear and tear destroys the articular cartilage, degenerative joint disorder that leads to inflammation with inadequate repair. So pathogenesis will give mechanical, that is wear and tear will destroy the articular cartilage, degenerative joint disorder with inflammation that leads to inflammation with inadequate repair. Chondrocyte mediate the degradation and inadequate repair. Chondrocytes will mediate the degradation and inadequate repair. Okay, predisposing factors are age, female, obesity, and joint trauma. Presentation: it will present with a pain in the weight bearing joints after use, for example, at the end of the day. So osteoarthritis present with a pain at the end of the day, improving with rest. Asymmetric joint involvement. Knee cartilage loss begins medially, that is bow-legged. So if the bow-legged, if the knee cartilage loss is bow-legged, I guess it is genoverum deformity, and then no systemic symptoms will be found. We'll see that in the rheumatoid arthritis. So it is the osteoarthritis mostly is a mechanical disorder and happens in the obese female patients presents the pain and asymmetric joint involvement, knee cartilage loss will cause bow legs, and there is no systemic symptoms. In the case of rheumatoid arthritis, it is an autoimmune inflammation of the synovium, induces formation of pannus, proliferative granulation tissue, which erodes the articular cartilage and bone. The granulation tissue contains myofibroblasts, which cause the joint deformity. Female HLA-DR4, that is four-walled rheum. Okay, that's a very pathetic mnemonic, but you may remember it like that. So HLA-DR4, it is a four-walled rheum smoking. Positive rheumatoid factor IgM antibody that targets the IgG-Fc region in 80%. Anticyclic citrullinated peptide antibody, more specific. Pain, swelling, and morning stiffness lasting for more than 1 hour, improving with use. Symmetric joint involvement. Systemic symptoms, for example, fever, fatigue, and weight loss, and extra-articular symptoms. Extra-articular manifestations are common. Then these are continuation of that. The joint findings in the case of osteoarthritis. So this is osteo1. Osteoarthritis joint manifestation can be as follows: osteophytes or bone spurs, bony projections that form along the joint margins, asymmetrical joint space narrowing from loss of articular cartilage. Then we have subchondral sclerosis, thickening of the bone in joints and cysts. Synovial joint non-inflammatory, WBC will be less than 2000. So synovial joint, synovial fluid will be non-inflammatory, that is WBC. Normally WBCs are present in the synovial fluid, and in the case of osteoarthritis, although it is an inflammation, but it will be the fluid of the synovium will be non-inflammatory. WBCs will be less than 2000 per millimeter cube. The affected joints are large joints, which can be knee or hips, distal interphalangeal joints, that is called as Haberden nodes. So in the picture B, you can see the Haberden nodes over here, and then the proximal interphalangeal joint, which is called the Bouchard nodes. These are the Bouchard nodes, and these are the Haberden nodes. Both of them are seen in the case of osteoarthritis. The primary metacarpal joint. So first metacarpal joint and no metacarpophalangeal joint is involved. In the case of osteoarthritis, metacarpophalangeal joints are spared; they are not involved. Okay. The distal interphalangeal joints, proximal interphalangeal joint, and first metacarpal joint is involved. Treatment is with the acetaminophen and NSAIDs, intra-articular glucocorticoids. For the rheumatoid arthritis, the joint findings are margin erosions, periarticular osteopenia, soft tissue swelling, subchondral cyst, and joint space narrowing. Deformities include cervical subluxation, ulnar finger deviation. So fingers will be deviated to the ulnar side. They don't have shown a picture of that, but the fingers move medially. Okay. Then we have swan neck deformity or Bottomless deformity. So this is swan neck deformity, and this is Bottomless deformity. Okay. The synovial fluid is inflammatory, that is WBCs will be more than 2000. Small joints, metacarpophalangeal joint, proximal interphalangeal joint, and wrist joints. Note distal interphalangeal or first metacarpal. The distal interphalangeal joints are spared. In the case of this thing, like in the rheumatoid arthritis, the distal interphalangeal joints are spared, while in osteoarthritis they are involved. Cervical spine involvement, subluxation, and cord compression will also be found. Treatment is with the NSAIDs and glucocorticoids. Disease modifying drugs, for example, methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide. Biologic agents, for example, tumor necrosis factor alpha inhibitors can also be given for the rheumatoid arthritis. I guess it is infliximab, that is TNF alpha inhibitor. So normal spine looks like this. Osteoarthritic spine will look like this with the bone spurs and the narrowed disc and stuff like that. Loss of cartilage, formation of pannus, inflamed synovium, and erosion. These are characteristics of this thing, I guess rheumatoid arthritis. Moving forward to this picture, here we have femur and tibia. There is no sign of osteoarthritis. When the osteoarthritis begins, the joint space becomes narrowed, and there will be osteophytes, if you can see in the zone picture. So here you can see the osteophytes or the bony spurs are being formed. Then these are osteophytes over here. Then subchondral cyst with sclerotic margins. After that, we can see the subchondral sclerosis, and osteophytes are present over here. Okay, so these are subchondral stenosis and osteophytes which are present over here, like over here. Then rheumatoid arthritis. Rheumatoid arthritis is associated with a soft tissue swelling, periarticular osteopenia, joint space narrowing, and marginal erosion will be there. And you can also find ulnar erosion, ulnar deviation, that is all the fingers are moved to the ulnar side. X-ray of the hand can show ulnar deviation. Then we have musculoskeletal, okay, just give me a second. So these are swan neck deformity pathogenesis. So distal interphalangeal joint is bent because the distal interphalangeal joint is paired in the case of rheumatoid arthritis, and proximal interphalangeal joint in hyper extension. Okay, so swan neck deformity of the fingers, hyperextension of the proximal interphalangeal joint with the flexion of distal interphalangeal joints. In swan neck deformity, we find the hyperextension of the proximal interphalangeal joints. The proximal ones are hyperextended, as you can see in this picture, and there is flexion of the distal interphalangeal joints. So this gives us swan neck picture. What is bottonius deformity of the fingers? Hyperextension of the distal interphalangeal joint. The distal interphalangeal joint is hyperextended. Okay, and metacarpophalangeal joint. Hyperextension of these two extremes, like distal interphalangeal joint and the metacarpophalangeal joint, by the flexion of proximal interphalangeal joint. Okay, so in the swan neck deformity, distal is flexed, the proximal is hyperextended. In bottonius, the extremes are hyperextended, like the distal and the metacarpophalangeal joint are hyperextended, but the proximal interphalangeal joint is flexed. So these are two findings. So here you can see that there are two types of nodes. First one is Haberden node in the distal interphalangeal joint, and in the proximal interphalangeal joint we find the Bouchard's node. Then extra articular manifestation of rheumatoid arthritis include these 3, 4, 5 manifestations in the musculoskeletal system, in the lungs, in the blood, in the CVS and others. So for osteoarthritis we don't have any systemic manifestation because that is a local mechanical condition, while the rheumatoid arthritis, that is an autoimmune condition. So in that case we have manifestations, systemic manifestations. The first one is rheumatoid nodules, fibroid necrosis with the palisading histiocytes in subcutaneous tissue and lung with pneumoconiosis. Okay, so the rheumatoid nodules, which are fibroid necrosis in the palisading histiocyte in subcutaneous tissues and lungs, if that thing happens along with the pneumoconiosis, that is called as Kaplan syndrome, Baker cyst and carpal tunnel syndrome. In the lungs we find interstitial lung disease and pleuritis. For the blood, we can have anemia of chronic disease and neutropenia with splenomegaly, that is Felty's syndrome. In the CVS, pericarditis and vasculitis can be seen, and other areas we can find AA amyloidosis, Sjogren syndrome, scleritis and lymphadenopathy, which can be associated with the rheumatoid arthritis. Now let's look at the risk factors for the osteoarthritis. The risk factors for the osteoarthritis are either modifiable or non-modifiable risk factors. The modifiable risk factors are sedentary life, obesity, occupational joint loading and diabetes mellitus. The non-modifiable risk factors are advanced age, female sex, family history, abnormal joint alignment and the poor joint trauma, and prior joint trauma. The clinical features of rheumatoid arthritis include clinical presentation will show pain, swelling and morning stiffness in multiple joints, small joints, for example proximal interphalangeal joint, metacarpophalangeal and metatarsophalangeal joints, spare the distal interphalangeal joints, systemic symptoms, for example fever, weight loss and anemia, and cervical spine involvement, which includes subluxation and cord compression. Laboratory imaging study will show positive rheumatoid factors and anti-CCP antibodies. Okay, C-reactive protein and ESR correlate with the disease activity. X-ray will show soft tissue swelling, joint space narrowing and bony erosions. Okay, so let's come back to the Uworld point. So the Uworld point is the foundation of management of rheumatoid arthritis is the DMARDs, or disease modifying anti-rheumatic drugs, alleviate the pain and inflammation, reduce the long-term destruction and disability. They will reduce the long-term joint destruction and disability. The response to DMARD therapy is typically going to take weeks. NSAIDs and glucocorticoids can provide the rapid symptom relief in the interim. Examples of DMARDs are methotrexate, typically first line, sulfasalazine, hydroxychloroquine, minocycline, tumor necrosis factor alpha inhibitors. Okay, now we'll talk about the seronegative spondyloarthritis. Arthritis without the rheumatoid factor, that is no anti-IgG antibodies. So in the person who is having rheumatoid arthritis, there will be IgM antibodies which will be directed against IgG. So IgM against IgG is called as rheumatoid factor. So if a person has symptoms of rheumatoid arthritis but there is no rheumatoid factor, so that is called as seronegative spondyloarthritis. Strong association with HLA-B27 MHC class 1 serotype. We'll study that in the immunology sections, inshallah. Subtype is pair. Subtypes share the variable occurrence of inflammatory back pain associated with the morning stiffness. Subtypes which are PAIR. What's that? I don't know. Okay, these are the subtypes. The psoriatic arthritis, then it can be ankylosing spondylitis, then I is for inflammatory bowel disease, and R is for the reactive arthritis. These are the subtypes of seronegative spondyloarthritis. Yep. So the subtypes share the variable occurrence of inflammatory back pain associated with the morning stiffness improved with exercise, peripheral arthritis and enthesitis, which is inflamed insertion site of the tendons, for example Achilles tendon, and dactylitis, which are sausage fingers, and uveitis. Okay. So there is a variable occurrence of inflammatory symptoms which can be back pain, peripheral arthritis, enthesitis, dactylitis, and uveitis. We'll see them one by one in the next session. Until then, Allah Hafiz and Fi Amanillah.